Welcome. This is the CanVector National Thrombosis Seminar. I want to welcome everybody here. So just to remind you that CanVector National Thrombosis Seminar is a monthly seminar hosted live throughout the academic year, featuring our state-of-the-art thrombosis and VT lectures presented by both Canadian and international experts. And all the seminars are recorded. So in case if you were to miss it or if you want to refer back. The important thing is that the seminar is a self-approved group learning activity for which you can receive credits for minutes of accreditation program from the Roy College. And we will have later today, we'll have kind of some more information for you about getting the credit if you are interested. So this year, the seminar is, we have the planning committee listed here, including myself and our 4 other members. I really appreciate all the planning committee members' hard work in the past year to make this possible. Today is actually the last and final seminar of the year, and we have the honor and pleasure of having a very excellent speaker, Dr. Jeff White, to discuss with us entitled News at 11, Moving Beyond the Factor 10A Inhibitors. Dr. Jeffrey Weiss is a professor of medicine and biochemistry and biomedical sciences at McMaster University, executive director of the Thrombosis and Atherosclerotic Research Institute, and past president of the Council for the International Society on Thrombosis and Hemostasis. He's board certified in internal medicine, hematology, and medical oncology. And Dr. Weiss focuses on clinical practices on patients with thrombotic disorders. His research spans the spectrum from basic studies in the biochemistry of blood coagulation and fibrinolysis to animal models of thrombosis and on the clinical trial of antithrombotic therapy. The breadth of his work is highlighted by his over 640 publications in prestigious journals as diverse as Journal of Clinical Investigation, Journal of Biological Chemistry, Biochemistry, Circulation, Blood, Annals of Internal Medicine, New England Journal of Medicine, and Lancet, and 65 book chapters. He's a recipient of numerous rewards. Dr. Weiss is a fellow of the American Heart Association, the Royal Society of Canada, and the Canadian Academy of Health Sciences. So in this lecture, these are the learning objectives that's listed here. Dr. Weiss will review the differential roles of factor 11 in thrombosis and hemostasis and discuss, factor 11 inhibitors under development, as well as some results of the phase 2 and upcoming phase 3 studies, and identifying opportunities and challenges for this new anticoagulant. So just as a brief reminder, there will be a 15-minute Q&A period at the end, but please feel free to submit your questions throughout the seminar. And without further ado, Dr. Weiss.
Can you see my slides?
Yes.
Thank you. Well, thank you very much for that kind introduction. And as was discussed, this morning we're going to talk about factor 11 inhibitors. Before I begin, let me show you my disclosures. I'll give you a moment to read them. Now, what I'm going to talk about in the next 25 minutes or so, first, I'm going to discuss why we need new targets for anticoagulants. I'm going to discuss the drugs that address these targets, and I'm going to talk about some of the new indications for this new class of anticoagulant agents. Now, I don't have to tell this audience that the direct oral anticoagulants are a huge advance over vitamin K antagonists like warfarin. They're at least as effective for stroke prevention and atrial fibrillation and for prevention of recurrent venous thromboembolism, but they're safer. In particular, the direct oral anticoagulants are safer for the brain, with about a 50% reduction in the risk of intracranial bleeding with the direct oral anticoagulants over warfarin, and in this VTE space, about a 40% reduction in major bleeding. So then why do we need new agents? Well, let's remember that the goal of anticoagulant therapy is to attenuate thrombosis without increasing the risk of bleeding. And although the direct oral anticoagulants, the DOACs, come closer to this goal than warfarin, we still have a ways to go. Even with the DOACs, the annual rates of major bleeding are about 2 to 3% in our elderly atrial fibrillation population. And if we add up the rate of major and clinically relevant non-major bleeding, we have rates at least 10 to 12% per year. And the problem is that the fear of bleeding leads to the underuse of anticoagulants for stroke prevention in atrial fibrillation. We estimate that even in the most recent registries, at least 30 to 35% of eligible patients with atrial fibrillation are not receiving anticoagulant prophylaxis. And in addition, the fear of bleeding is responsible, at least in part, for the inappropriate use of low-dose direct oral anticoagulant regimens, which leaves our patients underprotected. Now, let's remember that there are two distinct pathways by which coagulation can get activated. We're all familiar with the tissue factor pathway, which is responsible for most cases of arterial and venous thrombosis. But there's also the contact pathway. This is the pathway that is activated when blood comes into contact with medical devices such as stents or mechanical heart valves or central venous catheters. Our current anticoagulants target factor 10A or thrombin, which are downstream in the common pathway of coagulation. And what we're going to be talking about is upstream inhibition at the level of factor 11A, which resides here in the intrinsic pathway. And why are we focusing on the contact pathway? Because attenuation of thrombosis without disruption of hemostasis is a reality with inhibition of factor 11 or factor 12. And let me show you why. In this schema, you see on the left-hand side the process of hemostasis. This is predominantly an extravascular process, which is triggered by the high concentrations of tissue factor in the hemostatic envelope that surrounds blood vessels. When that blood vessel is cut and this blood is exposed to this high concentration of tissue factor, there's explosive thrombin generation, which initiates the formation of the hemostatic plug that seals the leak and prevents blood from getting out of the vessel. In this process, feedback activation of factor 11 by thrombin is mostly dispensable. It's rarely required. This is why patients with factor 11 deficiency rarely have spontaneous bleeding. Thrombosis, on the other hand, which is an intravascular process, is triggered by small amounts of tissue factor that's exposed to the blood, for example, when an atherosclerotic plaque ruptures. This triggers the generation of a small amount of thrombin, which then feeds back to activate factor 11, amplifying factor 10A in thrombin generation and leading to growth, and extension. Because of the differential effect of factor 11 in thrombosis, where it's essential, and in hemostasis, where it's mostly dispensable, inhibition of factor 11 has the potential to attenuate thrombosis with little disruption of hemostasis. Now, we have a lot of evidence supporting factor 11 as a target. Subjects with congenital factor 11 deficiency are at reduced risks of thrombosis and rarely experience spontaneous bleeding. We have genetic epidemiology studies that show in large cohorts of subjects that the risk of thrombosis is higher in patients or in subjects with elevated levels of factor 11 compared with those with normal levels, and lower in those with reduced levels of factor 11. And finally, we have animal studies in mice and rabbits and monkeys and baboons that show that attenuation of factor or inhibition of factor 11 attenuates arterial or venous thrombosis, and there's no increase in bleeding. And this is different from what is seen with the DOACs, where you get the same attenuation of thrombosis, but there is an associated dose-dependent increase in bleeding. Now, there are several strategies that are being used to target factor 11. We have antisense oligonucleotides that reduce the hepatic synthesis of factor 11, thereby lowering factor 11 levels down to levels that we see in individuals with congenital factor 11 deficiency. We have antibodies that bind to factor 11 and either block its activation, block its activity, or block both. And finally, we have small molecules that bind reversibly to the active site of factor 11 and block its activity. Now, here I show the results of a meta-analysis of phase 2 studies comparing factor 11 inhibitors with enoxaparin, a low molecular weight heparin, in patients undergoing elective total knee replacement surgery. We have a study with the antisense oligonucleotide, studies with two antibodies, asocimab, which inhibits factor 11A, and apelacimab, which binds to factor 11 and blocks its activation by both factor 12A and thrombin. And we have a study with milvexian, a small molecule inhibitor of factor 11A. And you can see in this meta-analysis that the factor 11 inhibitors were associated with about a 40% reduction in the risk of venous thromboembolism compared with enoxaparin, and about a 60% reduction in the risk of major clinically relevant non-major bleeding. So very supportive of the notion that factor 11 inhibition is both effective for preventing thrombosis after knee surgery, an event that is tissue factor driven and has the potential to be safer than currently used agents such as enoxaparin. Now, we have phase 2 studies with asundexian. It is a small molecule inhibitor of factor 11A. It's given orally. Like the DOACs, it has a rapid time to peak drug levels, 1 to 4 hours, and it has a half-life that permits once daily administration. And asundexian was studied in phase 2 in atrial fibrillation, in stroke, and in patients with acute MI. Let's review the results of those phase 2 studies. In the Pacific AF study, this was a phase 2 study in patients with atrial fibrillation, and subjects were randomized to either 50 or 20 milligrams of asundexian given once daily, or to apixaban in the usual dose of 5 milligrams twice daily. 250 subjects in each dose, in each drug arm. So a small study over only 750 patients. And the primary outcome was safety, which was bleeding, ISTH major and clinically relevant non-major bleeding, and the extent of factor 11 inhibition. Treatment was given only for 3 months. Here we see the factor 11 activity inhibition data, and with these doses of asundexian, there was almost complete inhibition of factor 11 activity at peak and even at trough with the 50 milligram dose. How this inhibition of factor 11 activity correlates with clinical outcomes, either bleeding or efficacy, is still unknown. And here are the safety data, and you can see that compared with apixaban, which we consider one of the gold standards for stroke prevention and atrial fibrillation, asundexian was associated with about a 66% reduction in the risk of major or clinically relevant non-major bleeds. Now, this was a relatively low-risk population of patients. They were treated for only 3 months. There were no major bleeds in any of the patients. So really, this reflects a reduction in clinically relevant non-major bleeding, but it's promising for a future investigation. Next, attention focused on stroke prevention in patients with non-cardioembolic ischemic stroke. Remember that about 25% of ischemic strokes are cardioembolic, mostly in patients with atrial fibrillation. The remainder are non-cardioembolic ischemic strokes due to several other pathophysiologies. The current standard of care is antiplatelet therapy, often with dual antiplatelet therapy with aspirin and clopidogrel for the first 3 to 4 weeks, followed by aspirin alone thereafter. The problem is that even with antiplatelet therapy, there's a substantial rate of recurrence, about 6% per year. So the question is, can we add a factor 11 inhibitor on top of antiplatelet therapy and get safe secondary prevention of recurrent stroke? In the Pacific Stroke study, subjects were randomized within 48 hours of the onset of their stroke symptoms to receive either 10, 20, or 50 milligrams of asundexian once daily or placebo. All patients got background antiplatelet therapy. Treatment was given to 6 to 12 months, and about 2,000 patients were enrolled. Now, you probably can't read this slide, but the important point is that the primary efficacy outcome was recurrent symptomatic stroke or covert stroke found on repeat brain imaging. There was no significant reduction in that efficacy outcome with any of the doses of asundexian. In terms of safety, there was no significant increase in the composite of major or clinically relevant non-major bleeding compared with placebo, and this is on top of antiplatelet therapy. Here you see the bleeding outcomes. You can see the hazard ratio of all the groups of asundexian combined is 1.57. That 3.9% with asundexian compared to 2.4% with placebo. So the point estimate is higher, but this difference was not significant statistically. If you look at all bleeding, again, not a significantly higher rate of bleeds with asundexian compared with placebo. In a post hoc analysis, focusing only on those patients who had a non-cardioembolic stroke associated with evidence of small or large vessel atherosclerosis, there was about a 60% reduction in the risk of recurrent symptomatic stroke with asundexian at the highest dose compared with placebo. So an interesting finding needs confirmation. The Pacific AMI trial enrolled about 1,600 patients with recent MI. About half had ST elevation MI. The other half had non-ST elevation MI. They were randomized within 5 days of their MI, and all patients received dual antiplatelet therapy, and 80% of the patients received aspirin plus ticagrelor as their dual antiplatelet therapy, so potent P2Y12 inhibition. Patients were randomized to placebo or to 10, 20, or 50 milligrams of asundexian, about 400 subjects per group. Again, asundexian produced a dose-dependent inhibition of factor 11A activity. At the 50 milligram dose, over 90% inhibition of factor 11A activity, both at trough and peak. If we look at significant bleeding, that's the composite of BARC 2, 3, or 5, very similar to the composite of major or clinically relevant non-major bleeding in the ISTH classification. You can see that asundexian, all doses versus placebo, there's no significant increase in bleeding. And the 50 milligram dose, 10.5% with asundexian versus 9% with placebo, a 20% increase that was not statistically significant. Now, the exploratory efficacy outcome was the composite of cardiovascular death, MI, stroke, or stent thrombosis, and no evidence of a dose response here with asundexian compared with placebo. But we know from previous trials with the direct oral anticoagulants in this setting that you're not going to see an effect on this outcome with such small numbers of subjects in the groups. Let's turn our attention to milvexian, the other small molecule inhibitor of factor 11A. Again, rapid time to peak after oral absorption, a half-life that permits once or twice daily dosing, and phase 2 data in total knee replacement surgery. I showed you that in the meta-analysis, and for secondary stroke prevention. The same sorts of patients as in the asundexian stroke study, except this study focused on those who had visible atherosclerotic disease. They were randomized to doses of milvexian that ranged from 25 milligrams once a day to 200 milligrams twice a day. Treatment was given for 3 months, and all participants got dual antiplatelet therapy with aspirin plus clopidogrel for 21 days, followed by aspirin alone thereafter. Once again, there was no dose response for the primary composite endpoint of symptomatic ischemic stroke and covert brain infarction on repeat imaging. But milvexian was associated with fewer symptomatic ischemic strokes at all doses, except for the highest dose. There was about a 30% reduction in recurrent symptomatic stroke with milvexian compared with placebo. There was no significant increase in major or clinically relevant a non-major bleeding. So where are we going with the factor 11 inhibitors? And we have ongoing phase 3 clinical trials that will enroll over 78,000 patients. Abelacimab, the antibody that binds to factor 11 and blocks its activation, is being evaluated in patients with atrial fibrillation who are deemed unsuitable for oral anticoagulants, where it's being compared then with placebo in the LILAC-TIMI 76 trial. Aster and Magnolia are trials in patients with cancer-associated venous thromboembolism. Aster is comparing abelacimab with apixaban and Magnolia with dalteparin. And abelacimab is given initially as an intravenous infusion and then subcutaneously once monthly thereafter. In the VTE patients, for the AF patients, it's given solely by monthly subcutaneous injection. Asundexian, the small molecule inhibitor that's being developed by Bayer, is being studied in AF, where it's being compared with apixaban in the Oceanic AF trial, and for secondary stroke prevention, where it's being compared with placebo on top of antiplatelet therapy in the Oceanic Stroke study. 18,000 patients plan to be enrolled in the AF trial, 9,000 in the secondary stroke prevention trial. With milvexian, the other small molecule inhibitor of 11A that's being developed jointly by Bristol Myers Squibb and Janssen, it's being compared with apixaban in the Librexia AF trial. It's being compared with placebo on top of antiplatelet therapy for secondary stroke prevention in the Librexia stroke trial. And it's being compared with placebo on top of antiplatelet therapy in patients with acute coronary syndrome in the Librexia ACS study. This ACS study is interesting because it will be treatment for extended treatment for a year or longer, with the hope that we'll see the early benefit that was seen in Atlas with a reduction in recurrent ischemic events, but without the increase in bleeding, and the long-term secondary prevention benefits seen in COMPASS when a low dose of a DOAC was added on top of aspirin. You can see the numbers of patients that are planned to be enrolled in these studies. So the take-home messages: factor 11 is a promising target for new anticoagulants. We need the results of these phase 3 trials to determine their benefit-risk profile, either as a substitute for a DOAC in the atrial fibrillation setting, or the replacement for apixaban or dalteparin in the VTE cancer setting, or on top of antiplatelet therapy in the stroke or ACS setting. I think it's unlikely that now that the DOACs are going generic, the cost is coming down, the uptake is increasing. I think it's unlikely that the factor 11 inhibitors will replace the DOACs for all indications. They're going into some new indications like secondary stroke prevention and acute coronary syndrome. But even in AF, they may find new indications or use in the highest risk patients. Thank you for your attention. I'm happy to answer any questions. I'll stop sharing now.
Thank you, Dr. Weiss, for this really excellent, wonderful talk and give us kind of a really nice overview on factor 11 inhibitor. I think it's quite exciting that that we have kind of a little bit next generation anticoagulants. And I think, so just remind everybody to please feel free to put in the chat or actually I should say Q&A section. So I think we'll get started. We do have a kind of comments and question here from Ismail Reslan. Thank you for the great talk. What strategies were used to manage bleeding or reversal for surgical procedures in the phase 2 trials? Are those antidotes that work? And presumably factor 11 infusion would not be effective for these inhibitors.
Okay, a great question, one that's commonly asked. Of course, in the knee replacement studies, really there was no need for even thinking about reversal because treatment was for a short period of time. But in essence, it turns out that even in the phase 2 atrial fibrillation studies, in most cases, there was no reversal that was done or needed. And patients did undergo surgical procedures without any problems. So for example, in the studies in patients with end-stage kidney disease with asocimab or with fesomersen, the antisense oligonucleotide, subjects underwent renal transplantation without any reversal with factor 11 inhibition on board. There were no bleeding complications. And we had one patient in the Anthos knee study who had the knee replacement, then had a gunshot wound to the popliteal fossa and underwent surgical reconstruction without any bleeding. So I think we're going to enter a new paradigm where we'll be able to do many procedures without needing reversal. But you do bring up a point in terms of what would you do if someone required urgent surgery and they needed to have consideration for reversal. And certainly tranexamic acid would be a useful addition in patients undergoing any sort of surgical procedure. If you really ran into trouble, you can reverse fesomersen, the antisense, by giving replacement with either factor 11 concentration or concentrate or plasma. With the others, you can bypass the inhibition with a low dose of factor 7A. Someone's asking, would you do an epidural lumbar puncture? You know, until we have data on that, probably try and avoid that if we could. We don't really have information on that. But remember, with these oral agents, their half-lives are such that they're going to be given once or twice daily. So our management peri-procedurally is going to be very similar to the way we manage the once or twice daily DOACs around the time of procedures. So, you know, all you would have to do is hold the agent for a couple of days and you would probably be good to go for a lumbar puncture. More difficult to say what we would do if someone had a long-acting antibody or antisense oligo on board.
Yeah, thank you. That's a good point. Like you know, when you present all those trials, it also struck me that it's still the kind of dogma that when we start anticoagulation, we always ask patient to minimize or limit the antiplatelet agent. But a lot of the trials that you have presented, they are actually, you know, really adding on not just single antiplatelet, but double antiplatelet for those patients who has acute stroke or acute coronary syndrome. On top of that, you know, you're adding in anticoagulant. So I found that quite interesting. That really is changing, like you said, it's changing the paradigm or the thinking that we have nowadays.
Yes, but you know, although if you look on the clinicaltrials.gov website, you'll see these trials listed, especially the ones with milvexian, asundexian, but the sponsors are silent on the doses that are being used or the dosage regimens that are being used. So, you know, it may or may not be the same dose that's used for, say, stroke prevention, where you're going up against apixaban, versus, say, for secondary stroke prevention, where you're going up against placebo on top of antiplatelet therapy, even dual antiplatelet therapy in the case of the ACS patient.
Okay. I mean, speaking of the dose, actually, while we wait for other questions, if I may ask, I just curious in your thoughts about. I know these are all phase 2 trials, so they have limited number of patients. But you really, there are a couple of studies that we really don't see any dose response, for different dosages on the efficacy side. And again, I know it's all exploratory, so maybe this. Do you think it's just a power question, or I just find it interesting that even they did show that the reduction of factor 11 is sort of proportional to the dosage, but the efficacy so far we haven't seen that.
Well, I think that with milvexian, we took the tried and true step of doing a knee study, because there you can see the dose response for efficacy. And that study clearly showed that once you got to daily doses of 100 milligrams or more, it was more efficacious than enoxaparin. So there was a dose-dependent reduction in the risk of postoperative VTE with milvexian. The other indications, they're just underpowered for efficacy, grossly underpowered for efficacy.
Okay.
As someone's asking about the interaction between factor 11 inhibitors and TPA. I mean, there's no particular drug-drug interaction. And in fact, in the axiomatic stroke study, the secondary stroke prevention study, after we had some safety information with the first few hundred patients, we actually included patients who had undergone thrombolytic therapy and allowed them to be enrolled at 24 hours, starting at least 24 hours after their thrombolytic therapy. So I think there is the potential to use that as a treatment for the stroke, and then to go into the factor 11 inhibitor versus placebo study shortly thereafter.
Right. So, okay. So another question by Dr. Rita Selby. If the bleeding risk potentially lower based on mechanism, do you not see possibilities some of these drugs replacing independent DOAC in the future for other mainstream indications?
I think that's a great question, Rita. Thank you for asking it. The first challenge will be, if we take the atrial fibrillation patients, the first challenge will be showing that the factor 11 inhibitors are at least non-inferior for efficacy to a drug like apixaban. Then the thing is, are they going to be superior for safety? And I guess my answer to your question is really based on, I think it's going to become a matter of reimbursement. So are our payers going to pay a premium for an agent that is associated with let's say a 20% reduction in bleeding compared with a DOAC, if it's going to cost more? And I don't know what they're going. So I think it's a delicate question. Of course, we'd like safer agents, and if they are safer, we'd want to use them. But it's also going to be a matter of cost, and the DOACs are getting cheaper and cheaper as apixaban is now generic in Canada. The cost went down from about $120 a month down to $40 a month. So are we going to be able to beat that when we think about everything together? Do factor 11 inhibitors require lab monitoring? Again, they're not designed to be given with lab monitoring, just like the DOACs really weren't designed to be given with monitoring of, say, anti-factor 10A activity. But if you do want to know whether they're on board, the APTT would be your biomarker that you could look at. So you will be able to know that they're on board, which is going to be a little problematic in these trials to maintain blinding when you're going up against placebo, but have to discourage people from doing APTT determinations. But you won't have to monitor the APTT and adjust accordingly.
Okay. And Dr. Dave Siegel have a few questions. She said, thanks for the presentation. Any factor 11 inhibitor on the development or plans
Yeah.
for development for the treatment for acute VT that's non-cancer? Trial seems to be notably absent.
Yeah, it's a great question, Deb. Right now, no. And then you could ask, well, why not? I guess for the reason we've already discussed, the DOACs have sort of replaced the old tried and true heparin bridging to warfarin. And what's the unmet need there? I suppose with abelacimab, once monthly versus daily treatment, but I think the unmet need is less in the garden variety VTE patient, which is why they focused on the cancer VTE patients. And
Go ahead.
cost differential monoclonal antibodies, impossible to know what the cost of these agents is going to be, but you're probably right. It's going to cost more to use a monoclonal antibody or to use a antisense oligonucleotide than it would be for a small molecule drug, but no idea about costs.
So we have more questions. So amazing review as usual, Jeff. What is the evidence, epidemiology or animal studies that inhibition of factor 11 is effective in reducing arterial thrombosis? I think the epidemiological data you mentioned were on venous thromboembolism.
So the epidemiologic data in either individuals with congenital factor 11 deficiency or in the Mendelian randomization studies show that if your factor 11 levels are low, you have a reduced risk of stroke, of ischemic stroke. If your factor 11 levels are high, your risk of ischemic stroke is high. For MI, a little bit more ambiguous about whether your risk is reduced if you have low level of factor 11. Some studies suggest yes, others don't really show that. In terms of the animal studies, it doesn't matter whether you do an arterial or a venous injury. If you have factor 11 inhibitor on board, you can attenuate thrombosis. So both arterial and venous.
Okay, so I think the next question is a little bit also along the line of previous discussion of thrombolysis. Do you think we should measure levels factor 11 before the thrombolysis in stroke patients presenting in the window, or we could just use it safely?
Yeah, I think that you wouldn't necessarily measure the level of factor 11. You could measure the APTT, and you know how much factor 11 inhibitor was on board. I guess what you're saying, what if you have a patient who is in the secondary stroke prevention study, they're getting either a small molecule 11A inhibitor or they're getting placebo, you don't know which, and now they have a recurrent stroke. And they're, if the treatment of the stroke is going to depend on knowing the results. If someone had a bleed, for example, or a stroke, you need to know the results. The APTT could help you. And then you could decide what to do. And maybe if you thought it was unsafe, you could go and use thrombectomy if that was available or useful. So great question. Don't have all the answers yet.
Okay. So please feel free to continue to put in, these are really great questions and great discussion. I think while we are waiting for maybe a couple more questions to come in, I'll probably just kind of going back to I would be curious on your thoughts about, Jeff, I know we kind of touched upon this before with Dr. Rita's question too. How do you foresee that factor 11 inhibitor will change the landscape of anticoagulant? I know you mentioned that maybe we're looking at some more different indications. I wonder also, I think there are some studies about dialysis patient or catheter-related thrombosis that currently we have either limited data or we kind of extrapolate our data from DOAG.
Right. Well, right now there's there's no phase 3 study ongoing, although there is at least one being planned in the dialysis population. So that is a ripe area because right now we don't have any effective and safe anticoagulant strategy for dialysis patients who either have thrombosis or who are at risk of thrombosis. And so the idea would be that in the dialysis patients, factor 11 inhibition might be a very effective and safe way to reduce the risk of stroke in about the 20% of dialysis patients who have concomitant atrial fibrillation, but also reduce the risk of cardiovascular death, MI, or stroke in those individuals, even without atrial fibrillation. Remember that 50% of the deaths in dialysis patients are cardiovascular in origin. So it's an interesting area, Sufei. We don't have anything, even although many of us might be using the DOACs, even as that creatinine clearance goes lower and lower, we don't really have good efficacy and safety data. So that's an interesting patient population. I think in general, if these agents turn out to be effective and safe, we'll want to use them in many of these indications. And I think they'll be added to our armamentarium. But, we've already, at least I've seen, I'm sure many of you have seen the impact of affordability on choices of anticoagulants that patients have. And I'm not sure how these new agents will impact that. Fortunately, with the cost of the DOACs coming down, affordability is becoming less of an agent of a problem. But with these new agents, it might come back to the fore. Are these agents dialyzable? No, the antibodies aren't dialyzable. They're too large, and the small molecules are highly protein bound, so they're not really dialyzable. Are they cleared mainly by the kidneys? Well, of course, the antibodies aren't cleared by the kidneys at all, or neither is the antisense oligo. And the two small molecule inhibitors, they're cleared to a smaller extent by the kidneys than the current DOACs. So somewhere around 15 to 20% renal clearance. So less of an impact of renal dysfunction on their effect. And the impact of say CYP metabolism, a little bit more impactful for milvexian than for asundexian.
I found the liver metabolism interesting too, because I think in addition to dialysis patients, cirrhosis patient is also a very challenging population, right? So
Yeah,
I
I
don't
don't
know.
know. Yeah, no, as you know, they're prone to bleeding too. So yeah, nobody's going to start there. But you also
Of course.
brought up the idea of medical devices, right?
Right.
We saw the PROACT 10A study where apixaban was compared with warfarin in patients with mechanical heart valves, and the study had to be stopped early because of an excess of thromboembolic events. So clearly the DOACs are out for medical devices. Would a factor 11 inhibitor be better? Remember that devices trigger clotting through that intrinsic pathway, and factor 11 is right there as a root cause. So possible that might be a good indication for factor 11 inhibitors. But we have some preclinical information that says not all factor 11 inhibitors are created equal, and some are better than others for prevention of device-associated clotting. So more to come.
Nope. Very interesting. Yeah, I just found that mechanistically, you would think that, again, because factor 11 is working on the contact pathway, we think that it makes sense. Is there any upcoming studies that I know there's at the ASH, they present a very small study in catheter-related thrombosis. I don't know if of any upcoming study on particular study in the catheter-related thrombosis population.
There are plans, and there's that study that was with that AB023, and it has a name that I can't remember right now, but that antibody is interesting because it binds to factor 11 and blocks activation by factor 12A, but not activation by thrombin. So that will only block 12A activation of factor 11. That study is being expanded, and remember the cancer patients that are being enrolled in the Magnolia and Aster trials, many of them will have central venous catheters, so we'll have an idea about what happens in terms of catheter thrombosis, perhaps through those studies with abelacimab versus either dalteparin or with apixaban.
Of course, yeah. Speaking of factor 12, actually, I think I know that this talk is concentrating on factor 11 inhibition. Is there any like studies or upcoming things for using factor 12 inhibition for similar reasons?
Yeah, it's a great question, and it would make sense to test factor 12 inhibitors. Remember that I think for the general thrombosis indication, when tissue factors the driver, if you get thrombin generation, the thrombin can feed back and activate factor 11. So even if 12 were inhibited, you could still activate factor 11 and bypass your 12 inhibition. So I think we need some proof of concept studies to determine whether a factor 12 inhibitor is actually effective in preventing thrombosis in a tissue factor driven system, such as VTE after knee replacement surgery. Does a 12 inhibitor work there? If it did, that would be really important and interesting, because clearly factor 12 inhibitors could have the potential to be even safer than factor 11 inhibitors, because people with factor 12 deficiency don't bleed.
Mm-hmm. Yeah, I still remember, this was like, I don't know, 10 years ago when I first heard about factor 11, 12 presentation at ASH. I always thought that, oh, factor 12 makes more sense because those patients have no bleeding, while
right.
factor 11 still have some, even though
Right.
it's quite minimum.
But the epidemiologic data don't really support factor 12 as a target either, because patients with congenital factor 12 deficiency, they don't appear to be protected from thrombosis. And in fact, there have been a few reports that there's an increased risk of thrombosis. And of course, John Hageman died of a pulmonary embolism associated with a hip fracture. So more to come, more to learn. And I think right now, my bet is on factor 11. And if it's before your time, Sufei, but in the beginning days of the DOACs, we would have debates of, is 10A or thrombin the better target? And now at the European Hematology Association meeting, I'm having a debate with Thomas Rene, is 12 or 11 the better target? And I'm saying 11 before 12.
Yes, yeah, it certainly looks that way right now. And I think you are absolutely right. Maybe it's related with the thrombin, reactivation of factor 11. Very good. I think I see no other questions as of now. And I think we're getting to the end of our time. And I want to thank Dr. Wise again for this excellent talk, and so more to come. And this actually concludes of our 2022 and 2023 series. Again, past seminars, just a reminder, are available on the website. And since this is the last seminar of the year, we also want to actually remind you that if you wish to have a certificate of attendance of all the seminars throughout the year, you will be getting an email from CanVector, and please complete. It's a simple form to complete. And again, this includes all the seminars you have attended in the past year via this email. And then the staff, our wonderful staff from CanVector, will send you the certificate for the credits that you have attended. So thank you. I want to thank everybody's time. And again, thank you, Dr. Wise, for this wonderful talk. And I hope everybody have a great summer. And we will see you next year.
See you at ISTH.
Yep,
Bye-bye.
see you at ISTH.